Next, we have Maya Harris. She is the consultant urologist from Warwickshire. She's going to discuss with us the last minimally invasive energy source, which is the green light.
Hello, everyone. Many thanks for inviting me to present at this meeting. And I will start sharing my screen just now. And start presentation.
Just on your left.
Yeah. Can you see my screen?
Yes, Maya.
We can see your screen. Please click on slide 4, just next to the animation.
Yes.
Above menu.
Slide 4. There we are.
Done.
Sorry, I'm still quite new to this technology. So I'm going to talk to you about green light laser. And first, a little bit of a technical detail. It's a side-firing laser, which was first developed by AMS, but now is owned by Boston Scientific. And the modern machine is 180 watts. And it works by generating very high temperatures, which turn the prostate tissue into vapor. It also has a very small penetration depth, so you don't get charring and subsequent fibrosis. So that's a difference with some previous lasers used. So why use green light? I must admit to you all that I'm a great fan of this technology. You can see here on a picture a comparison of irrigation fluid after green light and TURP. So it causes much less bleeding, and there is no need for postoperative irrigation. And also the patient could have a catheter much earlier out. And also I like that there is no prostatic chips, so you don't need to wash them out or contact the patient with a histology subsequently. The use of a green light really is based on a paper which is now about 10 years old. Paper is called Goliath study, and it has shown that a green light laser is non-inferior to TURP in respect of IPSS decline postoperatively and also flow rate. But doing green light laser results in shorter hospital stay and less complications. So it has a favorable safety profile, and it has been NICE approved. I've been doing green light laser since 2015, and I would like to share with you some technical tips. I usually give gentamicin at induction and also tranexamic acid, so that results in practically bloodless field. The patient is positioned with their head up, and all the anesthetists are your best friends because of it, as frequently unfit patients undergo this procedure, and it's much easier for them to give anesthetic. The head up position is useful as you generate bubbles, and then they escape into the bladder. This is different to TURP, as in TURP you generate chips, and those those are heavier, so you need a patient head down. So to do a green light laser, you'll get a fiber, and the tip of a fiber gets so hot with a modern machine that it needs to be connected to its own irrigation system. And you get two settings, vapor, which is a high energy, and coagulation, which is a lower energy. I usually start the procedure by marking out a prostate by the Vero, and also pre-coagulating any large mucosal vessels. The interesting fact about green light laser, you can operate almost bloodlessly until you hit a large vessel. So I find it useful to have a bipolar diathermy probe, as it's not easy to stop bleeding from a large vessel just using green light laser. And with a bipolar diathermy probe, you can easily pass the probe without changing the scope and irrigation fluid, and cauterize troublesome bleeder. So I would like to discuss briefly what is the role of a green light laser with all the other various technologies. Certainly, it is useful for larger prostates, and as you experience advance, you tackle bigger and bigger prostates. It also independent of a shape to a degree, and really various considerations need to be taken kept in mind when you are discussing procedures for BPO in these days. So certainly green light laser is for an older patient who perhaps is not so concerned about possibility of a retrograde ejaculation after the procedure, and who wants a good flow following the procedure. But of course, some younger patients choose green light laser, as in my opinion, it is more definitive and lasting than less invasive, minimally invasive options such as UroLift, Resume, and iTrue. I also would like to briefly mention about the cost effectiveness, and with a green light laser, you get more IPSS improvement for the cost, according to this study. So, in conclusion, I would like to say that green light laser prostatectomy would continue to have a role in treatment of BPH as a part of a portfolio, especially for older patients with comorbidities and larger prostates and perhaps retention. Thank you for your attention, and please ask questions and comment on a Twitter where my handle is Urologist Maya.
Thank you, Maya. That's a very nice energy source to complete our minimally invasive surgical techniques portfolio.